When people picture pediatric ADHD, they imagine a very specific energy, a student physically unable to stay seated, interrupting the teacher, and constantly in motion. That kind of behavior demands an immediate response. Because it actively disrupts the flow of a classroom, it triggers a fast track to clinical evaluations, to parent-teacher conferences, and targeted treatment plans. Curious. But there is an entirely different presentation of ADHD. Meet the daydreamer. This is the student who reads the same paragraph 4 times without absorbing a word, who loses 3 pencils before lunch, and who consistently appears spacey during instruction. Crucially, this student isn't bouncing off the walls. Without the hyperactivity or impulsivity to catch a teacher's eye, they completely bypass the usual classroom alarms for intervention. When we measure an attention deficit strictly by how much it inconveniences the adults in the room, we end up labeling these struggling daydreamers as lazy or unmotivated, and that creates a massive structural blind spot in how we diagnose children. According to the CDC, approximately 11% of U.S. children are affected by pediatric ADHD, but that 11% is heavily skewed. Within that group, girls and students of color are dramatically underdiagnosed. These demographics are statistically far more likely to present with the quiet, inattentive type we just described. On top of that, they often consciously mask their symptoms to blend in with their peers and avoid drawing negative attention. Outwardly, they appear compliant. Inwardly, maintaining that facade requires immense cognitive effort, leading to profound mental exhaustion by the end of every single school day. Our reliance on highly visible stereotypes delays nettable care and drives systemic inequity, effectively hiding a manageable condition within our most vulnerable student populations. Inattentive ADHD is a specific, clinically recognized presentation of the disorder. It is entirely distinct from the normal, everyday experience of occasionally getting distracted. This diagram outlines rigid diagnostic criteria. A child under 17 must display at least 6 distinct symptoms of inattention, persisting for 6 months and originating before age 12. Those symptoms are specific cognitive roadblocks, an inability to sustain attention, careless mistakes on schoolwork, and consistent avoidance of activities requiring sustained mental effort. Then there are environmental factors, chronic forgetfulness and daily routines, consistently losing belongings like papers, and severe distractibility triggered by external stimuli. Meeting these strict criteria proves that chronic inattention is a pervasive neurological difference. The brain is processing inputs differently, rendering the old accusation that a student is just not trying hard enough scientifically invalid. Because these inattentive symptoms are entirely internal, mapping them accurately is complex. A proper evaluation can never come from a quick social media quiz, nor can it be based on a single teacher's frustrated observation. It requires a rigorous medical process known as differential diagnosis. This is how clinicians systematically distinguish between multiple distinct conditions that share the exact same outward symptoms. This Venn diagram shows why that process is so vital. Inattention sits in the middle, but that behavior can be produced by severe anxiety, learning disorders, trauma, depression, or a chronic sleep disorder. Cutting through that overlap requires a licensed clinician. They rely on standardized screening tools, specifically the Vanderbilt rating scales, to meticulously cross-reference behavioral data reported by both parents and teachers. Inattention is a master of disguise. A comprehensive clinical evaluation is the only way to rule out competing factors and identify the specific support a student requires. Once accurately diagnosed, we turn to the gold standard of care. The landmark MTA study demonstrated definitively that a multimodal approach heavily outperforms any single intervention for moderate to severe cases of ADHD. Multimodal simply means combining therapies. The behavioral pillar focuses on targeted behavioral parent training, which is the absolute strongest intervention for younger children, alongside practical organizational coaching for the student. The educational pillar involves the school directly. This requires implementing specific classroom accommodations and structured behavior plans to support the student's daily environment. Finally, this framework includes a medical pillar. When clinically indicated by a pediatrician or psychiatrist, this involves pharmacotherapy, utilizing targeted stimulant or non-stimulant medications to help regulate the brain's executive functions. Handing a student a pill or simply asking a teacher to be more patient will fail in isolation. Lasting, functional success requires this interconnected triad working together in real time. However, a gold standard treatment plan remains out of reach if a family cannot overcome geographic distances or financial hurdles. MentalSpace School addresses these hurdles in Georgia by integrating comprehensive mental health infrastructure directly into the K-12 school environment. This chart maps out their actionable logistics. You can see the direct pathways connecting same-day teletherapy, dedicated therapist teams assigned to specific schools, and broad insurance acceptance, including a $0 tier for Medicaid. By centralizing these resources, they can facilitate the multimodal strategy in one place, coordinating care between medical prescribers, providing parent training, and conducting direct classroom consultations with teachers. This model serves as a blueprint for school districts. By redefining what ADHD looks like and integrating robust clinical support, we can stop punishing the quiet daydreamers and provide the clarity they need to thrive.